So good morning, everyone. And as per our every Thursday clinical meets, today we are going to discuss some interesting Genu Varum cases. Last week we had the basics of Genu Varum. All the fellows made presentations about the physiologic, exaggerated physiologic Genu Varum and the bilateral Genu Varum and unilateral Genu Varum with pathological cases. So we did how to assess, quantify the deformity, find out the origin of the deformity, and some basic principles of management we discussed briefly last time. So today we'll discuss cases, and we have experts in this field in the world, I would say, Dr. Sanjeev Sabharwal, who is a very dear colleague of POSI and is professor of orthopedics in San Francisco. So welcome, Dr. Sabharwal, and thanks for sparing your time for teaching us.
No, are you kidding? My pleasure. Thank you.
And our own Dr. Mangal Parihar, sir. Dr. Parihar is expert and he has educated most of us for deformity correction in India. So let's start cases, and then I'll talk and inquire with fellows, and then I will take expert opinion. And then ultimately we'll show what we have done, and they can guide us how we could have done it better. So let's see this case. There's the first one, 21 months old boy presented with Genu Varum deformity. He has waddling gait. Mother reports that he has inadequate milk intake, and parents say that deformity is progressing. There is no family history, and metabolic markers were equivocal. So as routine, the patient comes to us, they already have been prescribed vitamin D. So they have taken some sort of vitamin D, and but still the deformity is progressive, and this is how the child walks, and it is concerned to the family members. There's a bit of lateral thirst and acute angulation in the proximal tibia, typical waddling gait. This was a bit more than what we usually see in physiologic Genu Varum children at our place. So on clinical exam, the BMI was normal. Child was not too obese. Mainly it was tibial deformity, and there was acute angulation in proximal tibia and minimal lateral thirst. So this was the X-ray. So first, I would like to ask Gaurav, how would you read this X-ray? Are you there?
Yes, sir. So, sir, this is a full-length standing scanogram, AP view, showing severe Genu Varum, zone 4, and there's broadening of the distal metaphyses of femur, and there is some lucency at the metaphyseal region of the distal femur, which is suggestive of rickets.
Yeah, so I agree with you that mechanical axes are passing way medial, and there is cupping and fraying of distal femoral metaphysis. Surprisingly, we don't see similar changes in the proximal tibia, because when we see severe rickets or partly healed rickets, we would see changes on both the sides. So, Dr. Sabharwal, what would be your comment on this presentation and X-ray?
Yeah, no, you're right. I mean, you go back to the history again, and like you said, if there was inadequate milk intake, and that was perhaps one of the contributing reasons. And you mentioned on the blood work, the metabolic panel. Sometimes, if it's partially treated or even if it's untreated, some of the numbers may not be that different.
Yeah.
Sometimes, and I'm not an endocrinologist, but I think alkaline phosphatase is also a good marker in terms of, how the body is reacting to low vitamin D. And I agree with your comment that, the changes seem to be more obvious in the distal femur than the proximal tibia. Interestingly, the distal tibia, if anything, has a little bit of cupping. The proximal femur, on the other hand, does not. And I'm sure, you talked about it in the past too, that, based on first glance, without measuring all the angles, the joint orientation angles, etc., it looks like it's coming actually from both the femur and the tibia. So I'm not saying that we need to jump to any kind of surgical solution, but I think it's always a good habit, if possible, to quantify where the deformity is coming from, even in younger children. Although it's harder, and we can talk about it later.
Yeah.
Like how to modify the lines to look at, let's say, LDFA and MPTA in younger children.
Yeah, so that's very true that this is coming from both from femur and tibia. Dr. Mangal, your comments on this?
I agree with everything that has been said. Partly treated also can throw us off a little. One of the things I tend to go for almost every time in terms of the clinical examination is to look at the ribs. That's something that's always the rachitic rosary.
Yeah.
In all of these cases, you tend to find it. Sometimes it may be subtle, but it tends to be there.
Yeah. So we see, my wife is a pediatric endocrinologist, and so is my sister-in-law. So we see lots and lots of variety of nutritional deficiency, and as Dr. Mangal said, prominence of rib chondral cartilage are really important. So it was kind of deformity, and if we do measure all this tibiofemoral angle, and so all angles were pretty high range. So the question is, although in this case this was more obvious on the femoral side, but the young fellows, they would have always questioning themselves that whether this will progress or not, and will it end up into infantile tibia vara or early Blount's, or it will resolve as a physiologic. So these are few papers which were discussed in radiographic evaluation, that the proximal tibial metaphysio-diaphyseal angle and the epiphysio-metaphyseal angle, when it is more than 20 degrees, there are high chances of progression to Blount's. And the bracing was advised by Parihar and Rainey et al. When the metaphysio-diaphyseal angle is more than 16 degrees, especially when children have lateral thirst. Now the question is, already Sanjeev has partly suggested, but what should we do? Should we observe this child? How frequently? Is there any role of bracing? Or is there any role of early intervention to prevent any permanent physial changes to happen? Dr. Sabharwal.
Yeah, I mean, if this is the first time you're seeing, and it's pretty clear that the etiology is nutritional rickets, I think the mainstay is to, address the metabolic problem. Yeah. And I think in some ways, if the root cause is addressed, a lot of times the physes will sort of respond appropriately. So I don't think surgical intervention should be considered at this point. And I think bracing is a little bit all over the place in terms of, especially when it's bilateral, young child, how often are they going to comply? Does it really help? I don't think it hurts, but I don't think there's like a strong word to say bracing is going to fix everything. I think if given a choice, I think the metabolic route with vitamin D supplements, dietary modification is really the mainstay, and the parental education and follow up, every few months.
Yes, I agree with you. And we follow your paper, the review paper on Blount's or tibia vara. And for bilateral equal deformity, younger children, the role of bracing, we have insufficient evidence to follow that. So yeah, this is the paper now this was about Blount's, but we follow that on this patient. Again, there is a paper from Japan, and they are also of similar opinion that you observe, even in the presence of advanced radiological status, if deformity is progressive, then only there is question of intervention. So we just waited, treated the metabolic profile, and in 3 years' time, child gained height and it got corrected to straight like this. And it got corrected from here to here. And for some reason, they came to me to see at 10 years, and I could get this picture. So this was an exaggerated physiologic Genu Varum, where one needs to observe. And most of the children by the age of 3.5, 4 years, they get straight. If the deformity progresses, then only one should intervene. And the assessment of deformity progression is also, one can take some clinical pictures and follow every 4 to 6 months. So they may not need to repeat x-rays once the nutritional deficiency is cured. So we know, just for the knowledge, that we know this physiologic Genu Varum, it gets neutralized somewhere between 18 and 24 months, then it goes into valgus, maximum valgus at the age of 6 years, and then settles down at 7 degrees tibiofemoral angle at 8 years. And in nutritional deficiency, this gets a bit exaggerated. The limb alignment curve gets a bit lateralized, and children get straighter by the age of 3.5, 4 years. So that's the message for this. Thank you. So let's move on to the second case. Now, this is 1.5-year-old child presented with unilateral Genu Varum. There is no history of trauma, no history of infection, and the child has a unilateral Genu Varum, making the limb bit short, and so his gait pattern was quite abnormal. I could not dig out his video, but he had lateral thrust while he walked. So we can see that there is no signs of rickets here. So Charlene, would you like to read this X-ray? How would you read this X-ray?
Yes, sir. This is a standing AP X-ray of a skeletally immature child with unilateral Genu Varum. Most of the deformity comes from the tibia. There is no sign of active rickets, but
So any radiologic sign which would guide you about any pathology, or this can be seen. So Dr. Sabharwal, how frequently you see this unilateral Genu Varum?
I mean,
it's very rare.
Yeah. I mean, it's usually not physiologic if it's unilateral, yes. And if it's like a big difference, just like in this case, it's not a mild difference, it's a pretty substantial difference, both clinically and radiographically.
Yeah. So how would you go ahead with this? How should we observe it, or treat it, or brace it, or what can be done?
Yeah, I mean, again, going back to history and establishing, is it getting better, worse? When did the child start walking? And on exam, I think it's also good to see, like you mentioned, the left leg looks a little shorter. You can also look at the torsional profile, including the thigh foot angle. It looks like there may be a little bit of more internal tibial torsion on the left compared to the right.
Yeah.
So I think all those things are suggesting early onset Blount's, but you could have other things like the rear, although it doesn't look pretty classic. And radiographically too, you can see on the left side there's a little bit of a metaphyseal beak medially compared to the right.
Yeah.
The other interesting thing is even on X-rays you could think that this child may have internal tibial torsion, only because there's more overlap of the fibula on the proximal tibia, which means the child's trying to externally rotate the leg, or the radiology technician is, and then you can see more overlap. So, but I think it's quite likely this is early onset Blount's, but it could also be, although unlikely, but focal fibrocartilaginous dysplasia or something like that.
So that was, I was thinking that there is a bit of thickening of proximal tibia, just along the pacenserinous insertion.
Yeah.
But I had lateral view. Lateral view was looking okay. I mean, usually we see a cystic area. So we did those measurements, and they all are suggestive of a propensity to progress to early Blount's. Dr. Mangal, how would you manage this child, or how would you approach this child?
Observation, and then this usually gets referred to if such a child comes to me. In Mumbai, I think people are fairly knowledgeable about the specialty of pediatric orthopedics. So they tend to first land up with the pediatric orthopedic surgeon. So I don't see these very frequently. So I would observe, get my pediatric orthopedic friends in terms of opinion making, and then see how it goes as to what is the diagnosis. It seems like the start of early Blount's kind of thing.
Right. So, Dr. Sabharwal, now what should we? My question is: observation alone, or bracing, or intervention?
Yeah, I mean,
what would you choose?
I think 1.5 is a little bit young for intervention, but I think he will most likely end up with intervention. I'm not a big fan of bracing, but this is where you kind of gauge the family concern, resources, so if there is an indication, and again, I probably would not have braced, but I think even based on science and literature, whatever there is, I think this probably is a good indication for bracing, in that it's a non-obese patient, he's young, it's unilateral, and he has a little bit of a varus thrust, like you said. So I think on all that account, it would probably fit the brace category. And I think traditionally that's what people do, and some still do that. But I think the brace needs to be a certain type, and we can go into that.
So I'm either I'm not very great fan of bracing, but I read this the paper for unilateral bracing. I mean unilateral Genu Varum. There is some role of bracing, and parents were not ready for intervention. I've observed this child in 2 subsequent visits, and the Genu Varum was persistent. So we went on for the 3-point bracing. And this family was like in the fear of surgery. They were so religiously following bracing. They were very compliant. And this is 5-year follow-up of bracing treatment. So at the age of 6 years, he gradually got straighter. And now in retrospect, if I see the X-ray, the scanogram, I see some physeal scar in the center, you see, more on the medial side. So he might have some infection to start with, or some physeal injury, which was not evident on the first X-ray. But if we, did you get what I meant, Dr. Sabharwal? There is a mild here. See?
Yeah. No, I see that, but that could just be part of
normal thing.
No, residual Blount's changes in the Facets.
Okay.
I think that's probably what it is. And you can see Maulin, the leg is still a little short, but this is great. And I think this is a good sort of depiction of where a little bit of sort of observation, bracing, as opposed to, let's say, doing an osteotomy or something else, makes sense in a young child with this disease. So it's good. Well done.
So in India, we see some natural history out of fear of undergoing surgery, and most of them are not insured, and they like to try most conservative treatment. And I would have
one thing I would again point out is, like you mentioned, this child needs follow-up till skeletal maturity because of those
Yes.
physeal changes, the leg is short, and it may not be, I mean, it is likely that if his leg length discrepancy is
Yeah.
more than 1.5 to
And we can do
5
contralateral.
Yeah.
Yeah, I agree. And he still has a bit of the tibia vara. So let's see how it progresses.
Yeah.
I have tried to follow him up.
Maulin, I have a question for you.
Yes, sir.
How long would you, what is the interval that you would see the patient at? And at what point would you decide that this is not working? Meaning at 6 months, parents come and say, no, I'm not willing for surgery, I'm worried. At 1 year, parents say, at 1.5 years, when will you say that, okay, no, this is not working?
So like I tend to follow these children every 4 monthly. And every time we do a standing X-ray in presence of our fellows, so that we make sure that there's a proper and identical X-rays every time. And we measure this mechanical axis, and the parents readily understand that this is and if on 2 or 3 successive times, this mechanical axis, it fails to neutralize, or if it progresses, then every time I inform them that if it goes worse, then we have to intervene. And most parents, after 2 or 3 visits, they would agree if the child is not improving. And so we make it a shared decision. So for a child of 21 months, I would wait for a year, and at around the age of 2.5, 3, if it doesn't get back to, it's not improving, I would do an osteotomy. And then I will, the question is whether to do a growth modulation. So whenever I'm not aware of etiology, I try to do osteotomy rather than growth modulation, because that disease growth plate might be the primary reason of this deformity. Dr. Sabharwal, what is your approach?
I mean, I think growth modulation is a more benign procedure. And I think if you've got a little bit of time and growth remaining, which obviously this child, it's a non-issue because he doesn't need surgery. But let's say he got worse and he's 3 years old. I probably would choose growth modulation to osteotomy, only because in both cases, you're really not addressing the physis. The only thing is you're doing, with an osteotomy, you're doing a more acute correction and realigning the mechanical axis. So there is some advantage to that. But the flip side is the morbidity of an osteotomy, risk complications are much higher. So I think nowadays with the plates that are available, I personally, and there's 3 series, I think, saying that it's reasonably effective to do growth modulation, in the appropriate candidate, especially with early onset plants. So yeah, the pendulum, I think, is swinging a little bit.
Yeah. So I agree with that. And so that also depends on the family, family's education. When we do growth modulation, the parents should have enough intellect to understand that they have to come back at right time. Now I have 3 families where we started treatment for Genu Varum, and I had to repeat growth modulation for Genu Varum because they could not come back in time for removal. And some of them, they don't understand that the gradual correction has lesser morbidity, and they want an acute correction. So yes, up to 30, 35 degrees still we can do.
To that, I would say that that depends on how you bias them.
No, we have ample of patients for growth modulation. We can show them case examples, and always we would like to do an growth modulation. But when I feel that this physis is,
so that's what I'm saying. So it depends on how you bias them. If you are biased towards osteotomy, then that will come across. If I am biased about Elizarov, I will say कि ये बिना बड़ा incision किए इसको ठीक किया जा सकता है, and that becomes the selling point. On the other hand, if I want to sell them an open osteotomy, I would say कि ये एक झटके में सीधा हो जाएगा and 3 महीने के लिए वो रिंग लगा के रखने की जरूरत नहीं है. And you know, it will sell like that. It essentially comes down to, I think, to our own convictions also, as to how well we are able to. When you are convinced about a particular thing, it transmits to them, and they think that, oh, doc thinks this is better, so we'll go whatever you say, doc. And that happens everywhere. I'm sure it happens in the US to a large extent, and it happens to us. Doctor, to aap ho, humko kya pata, sir?
This is happening in mostly in brachial plexus world, because I mean they go to different center and everyone is swearing by their own regimen. And yesterday one patient came and told me, sir, in brachial plexus opinions are like black and white, because there are more specialties involved. Plastic surgeons, they would suggest nerve surgery, orthopedic surgeon would suggest anyway. So as you said, it is going, but we observe, and the goal is to make them straighter with minimal intervention. So the key learning point in this case would be a unilateral Genu Varum. There is some role of bracing, and you follow, and if they don't improve, then you go for growth modulation or corrective osteotomy.
One final thing I want to just in that X-ray, there is a circle over there in that earlier one.
Yeah.
If that's a marker, that's in the wrong place.
No, this is a magnification marker.
Exactly.
Which
So it's in the wrong place. When you do an AP, it has to be in the plane of the bone. So that is the same distance from the X-ray as the bone. In this position, this is the right position for a lateral X-ray, because then it's in the same plane. So it gives you the right magnification. You get my point?
Yeah. So I didn't get it. Sorry. So we put it in the front of thigh.
So if now, for example, if that is the thickness of the thigh, and the film is here, the ball should be here, not here, because if it's here, the ball is further away from the film than the femur. So you have a different magnification of the ball and a different magnification of the femur. So if this is the cross section of the femur, your ball has to be in the plane of the femur for an AP.
Okay.
And for a lateral, it has to be there.
Yeah.
Then you get the correct magnification.
So I'll talk to you about it, how we can put it on at the level of femur. So you can teach us that as well. Where would you put a marker in an AP X-ray? There's a coin of a rupee coin.
No. So you get a 30 mm. You go to the plumbing market. You'll get a 30 mm ball, which is part of a valve.
Okay.
Sew that into a cloth bag and put long Velcro straps on either side.
Okay. Understood.
You can just Velcro it and position it exactly where you want.
So it comes in just besides the femur level.
Yeah. So whatever orientation of the ball, you will still get a circle. If you're not right, it will move.
Right.
And it has to be at least 30 mm.
Right. Understood. Yeah. So we get in our digital X-ray, every 6 monthly we get this magnification test done with the height of beam. But when we get this X-ray outside, but now we'll find out this ball and do it. That's a good suggestion. So there are 26 participation. How to put Shalin, you got it? Yeah.
Yes.
You got the answer. Yeah. Okay. So let's move ahead now. So this is windswept deformity in a 4-year-old child. This is a child brought to us from Mother Teresa Foundation. These children, they are not very well taken care of before they go to the foundation. So nurses, they brought to us. And Sheenam, would you read this X-ray for us?
Yes, sir. Here in this X-ray, we can see the windswept deformity is there. Distal Facets of the femur right side. Femur is there is irregularity of the epiphysis on the both sides, bilateral distal femur. And,
you mean metaphysis, right?
Yes, sir.
Metaphysis.
Yes, sir. In the left side proximal tibia, we can see the physial and epiphyseal changes, and beaking on the left proximal tibia is there. It can be seen in the hypophosphatemic crickets, windswept deformity. So we will try to rule out that.
Yeah, so you could see the changes are more pronounced on the lateral metaphysis on the right side and the medial metaphysis on the left. And why is it like that? Shinam, can you tell that?
Yes, sir. Sir, it may be due to the pressure changes.
Yeah.
Due to
So
the
mechanical
pressure
axes are passing to the lateral and medial. Agree. So, Dr. Sabharwal, like, what is this pathophysiology of windswept deformity? Why this happens so? One side it is valgus and one side is varus.
I don't think anybody really knows, and windswept could be for multiple etiologies, right? I mean, here in a young child, as you and Shinam pointed out, you know, it's related to physis and juxtaphyseal. I think, you know, it's sort of the chicken and the egg thing, right? Did the physeal changes cause
Secondary
the
or
valgus
primary?
and the varus, or did the varus sort of put more pressure, or is it just a vicious cycle that, you know, a little bit of pressure, deformity, more pressure, more insult to injury? And then why one side more than the other? Honestly, I don't think anybody really has a sound mechanical reason other than to say maybe the way the child walked, or maybe both sides did not normalize from varus to valgus, like we had mentioned earlier, and one side was transitioning earlier than later, and then it became like a slippery slope. So, so there is obviously, I think for the trainees, there's the Hutter-Volkmann's principle, right? You want to pick on someone, Maulin, to ask them what that means?
Let me find out. The Charlene, you can answer. You have just appeared for DNB exam. So he is muted in the
Yes, sir. So the bone remodeling is directly linked to the pressure and the stresses to which it is put across. So the
form.
Yeah.
Form follows function, right? That's what the law is, right, Dr. Sabharwal?
Yeah, well, I mean, sometimes, you know, people get confused between Wolff's law and Hutter-Volkmann's, right? Wolff's law is mainly for bone remodeling, and Hutter-Volkmann's deals with compressive forces, causes growth inhibition, and then there is a corollary which is called Delpech law, which is that distraction forces can cause growth stimulation. So that's sort of the other part. Like, if you look at the right side, yes, there are physeal changes on the lateral side, but there perhaps is some widening on the medial side. And you could also say maybe there is some widening which may cause sometimes growth stimulation. So,
Right. So now, how would you, this patient's metabolic parameters are judged, and vitamin D and calcium has been started in therapeutic dosage. How would we treat this? Is it amenable to bracing, or would like to intervene at 4 years? What would you do?
you asking me?
Yes, you are the expert.
No, I'm not the expert, but I'll answer. So no, I think same principles like your first case with rickets. You know, if there is a metabolic anomaly, you treat that first. I personally don't think bracing has a huge role at this point with bilateral disease. So I would optimize him medically, continue follow-up, and then see what happens. And if needed, I think this would be a good case for growth modulation, but I wouldn't do that right now. I would first, you know, make
the
sure all the
disease should be.
Yeah.
So that's the same thing we followed, and with the metabolic, the treatment, the all X-ray changes disappeared, but deformity persisted, and we did growth modulation here. And so this is how one has to put medial growth plate on the Genu Varum side and the lateral on the Genu Varum side, and it gradually got corrected in a year's time. So again, the learning point is the for a windswept deformity, medical treatment followed by growth modulation if child fails to improve. Bracing is again not indicator, it's not very successful in these children. And particularly this child was not very cooperative either. So growth modulation can help. Fine, let's move to this case, 5-year-old boy. Now the history of this child, so he presented to me at 3 years. And at 3 years, he had minimal, so someone is asking at what point do we intervene growth modulation if it were hypophosphatemic rickets? Any particular blood parameters we should wait for to normalize? So for hypophosphatemic rickets, we usually see a global deformity where you would see the whole femur and tibia would have rounding. Now in this child particularly, there's a deformity is mainly around knee joint. And in hypophosphatemic rickets, we should not wait for the phosphorus to get normalized because their phosphorus is always going to be low. So we with little lower phosphorus level also we can do, and we follow alkaline phosphatase as well. So that's question that endocrinologists can answer. But I earlier on I thought that phosphorus should be in the normal level, but they never reach to that normal level because it is constant process. Before any intervention in hypophosphatemic rickets, the patient should be compliant with the pharmacotherapy for the phosphorus therapy. That's the key. Okay, so this child came to us at 3 years and he had milder deformity than what we see now, but and I suggested growth modulation at that point. The patient was extremely from poor strata, and they said that, sir, we will arrange for money and come. And it took 2 years for them to arrange the finances. And now this deformity was so grotesque, and I thought, why I let this child go? And the first thing I could have helped him. So this is how he walks. And this is the X-ray. So Gaurav, I would like you to read the X-ray and the gait pattern and what clinical findings strikes you while looking at this gait video.
So the child has severe Genu Varum, or we can call it a O deformity, with pintoing at the tibia and waddling at both the hips. And the X-rays is a standing scanogram showing severe bowing of the tibial metaphysis. And so majority of deformity is coming from the proximal tibial metaphysis.
Yeah, and there are some small irregularity at the metaphysis at the distal tibial level, more so on the right side, and there is acute angulation at this level with some sclerosis because of weight bearing. And so now the problem was this child is coming from a village, from a rural area. As we can see that they have limited resources. So Dr. Sabharwal, how would you read these X-ray, or what do you think is then probable etiology of Genu Varum in this child, which has progressed significantly in 2 years? Yeah.
I mean, initially I would have thought it could be Blount's, but, some changes don't look typical of Blount's on the X-rays. A couple of things. One, if you look at the proximal tibial epiphysis, it actually looks pretty even medial and lateral. In general, early onset Blount's, you would have decreased ossification, more of a metaphyseal beak, et cetera, et cetera. Also, there's almost like a translation, especially you could see it on the left side, his left side, translation of the metaphysis on the epiphysis. So, there are these descriptors of, something similar to a slip capital femoral epiphysis in the proximal tibia. That's
Right.
sort of been described, which, some people say is perhaps a variant of a skeletal dysplasia of sort. But I think given that he's coming from sort of, a resource poor environment, you should also, I guess, look at the nutritional part. But like you pointed out, most of the other phyces look fine. But definitely, it's not classic Blount's, that's for sure.
Yeah.
It could still be Blount's, but it's a little bit different.
So the same thing we thought. Even child did not for skeletal survey also they were not ready. But we got a spine X-ray free of cost, which was not showing any signs of abnormalities or any sort of dysplasia. So the key thing was we had to correct it. Now the question is how should we approach it? So Dr. Mangal, now this child, they are not intelligent enough to follow the frame application and gradual correction. And looking at this physis, the growth modulation will be kind of expecting a little too much for this deformity. How would you approach this problem within this scenario? And in the ideal scenario, how would you do it first, and then in this scenario?
You can, if you're able to do this with a acute correction, that can be done. It would be probably a closing wedge. I would accept stuff like translation and all at the moment. Do just a pure closing wedge, and then keep a watch. Now, I think even if we don't correct it completely, and there is a little bit of, I wouldn't kind of kill myself trying to get it perfectly straight, because right now what's happening is this amount of varus is impeding the medial growth. So if you unload that, then that growth is likely to get back to some semblance of normalcy. So no objection for a open closing wedge kind of osteotomy.
Let's say in an ideal scenario, patient is not restricted, what would be the ideal way of managing in your hands?
No, that would be good enough for this patient.
Okay.
Putting on an Ilizarov also has its challenges when you have younger ages with the epiphysis, etc.
Yeah. So we opted for an acute correction, and this, as Dr. Mangal said, we planned the fibular osteotomy and lateral closing wedge osteotomy. And I thought that this might be some form of this skeletal dysplasia, as Dr. Sabharwal mentioned. So this is what we could achieve, an acute correction on both the sides, fix it with multiple wires, lateral closing wedge, and we could made it straight. And there's a clinical picture on plaster removal at 1 month. And then this patient disappeared. So just before 2 days, I called them up and I said, can you come for an X-ray? And they said, no, we cannot come. I said, please send your clinical pictures. And so this is it. So there's a 4 years follow-up of that child. And I tried to overcorrect a little bit, and this is maintained. This is a little bit of valgus, bit of knocking. But the video which they sent is looking okay. I mean, it's not, they are happy, and it is not progressing. This is the same for last few years.
Oh, it looks great. Well done, really. My one thing just for the trainees is things you worry about are knocking off the perineal nerve, compartment syndrome, etc. So is there anything you advise to do when you're doing such a large acute correction?
So the most important thing is you do a percutaneous fasciotomy. The wound which you have opened, you open the the fascia with a mat Caesar right till the distal half of tibia, so that your compartment is released, and put a drain so that it does not lead to compartment syndrome. That is, and as it was a Genu Varum correction, we were not much worried about the lateral popliteal nerve injury. But when it is Genu Valgum correction, one should release that nerve first, then you do this big correction. Okay, so let's move on to now.
Even Genu Valgum, you keep a high index of suspicion for injury to the lateral popliteal, and if you find any weakness, go ahead and decompress it later. Meaning, the point I'm making is, don't say, okay, let's wait and watch. Decompress it. It's one of the sort of best. I've decompressed, some patients who have come to me after surgery, after a month, after 6 weeks, and they immediately start feeling the difference.
So the best way is to, once you finish your correction, you look at the peroneal nerve again and make sure that this is lax. Sometimes we see if it is very tight, you don't see vena committans on this. So I learned it from Dr. Nitin Giri Goswami here. I have done few corrections with him. So once you correct it, then again go and see what is happening to the nerve. But as you rightly said, we should release it. Yes, Gaurav?
One more point I want to make, Maulin.
Yes, sir.
Decompression of the lateral popliteal tends to be, many of us tend to think of it along the same lines as, say, a carpal tunnel. So it's not so much the nerve winding around the neck of the fibula that's important, but the branches which go inside, and especially the branch which is under the facial septum, between the lateral and the anterior compartment. So that this is one of the things where, if you have access to cadaveric dissection, it's a good thing to practice, and especially those of us who do deformity corrections and stuff, and make it a part of your toolkit, that whenever needed, go ahead and do the decompression.
Yes,
and
Gaurav,
has a beautiful, well illustrated article also on that, how to do it.
Yeah, so you share it, sir. I'll share with all the fellows.
Yeah,
Gaurav.
So I just wanted to see the post-correction X-ray, post-osteotomy X-ray. Yeah, so I mean that translation on the left side has almost corrected.
So this, I don't think that is translation, but that is a part which is not undergone weight bearing, and there might be cartilaginous thing,
No, but also look at the difference in the rotation between the full X-ray and the spot film.
So we have derotated also.
Okay.
Yeah, so that
even
was
then,
done.
even if you have derotated, your proximal fibula, see where it is on the full length X-ray, and see where it is on the spot film. So this so-called appearance, there may be an element of radiological positioning also.
Yeah. So even in the standing film, we can see patella is a bit lateralized. So it would have been difficult to take a proper X-ray. So I agree that that's true. Right.
Yeah,
so
just on that point though, sometimes it's okay to take one leg at a time, right? So if you can't fit both, just do one. Yeah.
So now this is interesting. Case number 5, a 5-year-old boy who had undergone 7 surgeries before coming to us. He had infection, drainage, debridement, non-union, plating, again non-union. And so he had undergone 6-7 surgeries before they came to us. And this is his picture, Genu Varum along with shortening of 5 centimeters. So Charlene, would you read this X-ray? What is your what you find on this X-ray? Then we'll go to Mangal.
Yes, so it's a X-ray of the leg of a skeletally mature child and shows post-infective status and atrophic non-union at the upper third of tibia, and with torsion of the tibia, which is evident by the tibiofibular overlap in the AP view.
Right.
And again, varus deformity, which occurs mainly at the non-union side of the tibia.
Right. So, Dr. Mangal, this case came just after I attended the Palakkad course with you and Vasudevan and Cherry. So that was a wonderful, and then I came to now please teach us about the X-ray findings and what are the important facets of treating this deformity.
X-ray findings, I mean, the way I look at it is, there is an oblique plane. You can see a deformity in the AP as well as the lateral.
Yeah.
That means that there is a deformity in a plane which is neither in the AP nor in the lateral. It's somewhere in between.
Anterolateral, yes.
So if you use the graphic method, you can calculate in which plane that is. That's number one. And then, since this looks like this wants to heal, a lot of people misread the sclerosis as bad bone. That's not true at all. Sclerosis can also be an attempt of nature throwing in more bone into that region. So once you've done a fibular osteotomy, if you find that this is in fact a stiff non-union, so this is a good case to just distract out the deformity using the principles of oblique plane correction, and these will ossify. So they've not ossified as yet because they've been in a biomechanically unsound position. The biology is fine, and once you distract it, you will find that this throws bone. Now that shortening of 5 centimeters, some of it is from the angulation, and some of it may be just because it has not grown well enough. You can't lengthen through that, or you shouldn't, I would say. You shouldn't lengthen through that distraction. The distraction of the non-union should be only to correct that deformity and make it straight. If at all, after correction of the deformity, you find that there is a little bit of discrepancy, then if you want to lengthen, you would need to do a separate osteotomy. Now, the other important thing of an oblique plane is that if you calculate what is the oblique plane, then you can use that funda even in open surgeries. Now, if someone talks about doing, say, let's say this was a deformity and not a non-union, and you want to talk of doing, so you would, people will say, I will do a anterolaterally based wedge. So how much is the wedge going to be on the lateral side? How much is it going to be on the anterior side? Versus that, if you just turn the deformity so that you have, you see no deformity. So that's the plane of no deformity. And then turn the C-arm into 90 degrees to that. Now you are seeing the plane of the full deformity, and then you can cut your wedge in that plane, and then use internal fixation if you want. So this oblique plane and stuff is not only related to Elizarov. It's a basic concept of deformity. You can use whatever it is that you want to, fix it later on. But you should get that concept that yes, this is an oblique plane.
Right. So that's I would recommend all the trainees to attend this deformity course where Mangal and Dr. Vasudevan, Cherry, they all organize a lovely course, and you will get to learn about it. Sir, is there any role of parathormone in pediatric non-unions? Dr. Sudhir.
My question is there any role of parathormone in any non-unions?
So in pediatrics, we have never used. Dr. Sanjeev, your take on that? He is deformities.
Yeah. No, yeah, not as first or second line. I don't. Firstly, I don't see that many non-unions in my practice, but yeah, I think like Mangal said, it's biology and biomechanics. Those are really the sound principles that your treatment needs to be based on. So, once you address the biology and the biomechanics, yes, parathormone and those kind of things are, needed very, very occasionally, but that's really not going to make the big difference in terms of, and especially in children, even if they've had multiple surgeries, unless the entire periosteum is totally gone, which I don't think is the case here. I don't think that's needed. One other point, and maybe when I saw this kid walking, he had a little bit of a hyperextension as well.
Yeah.
When I look at the lateral, maybe there is injury to the apophysis anteriorly, so that's just another, I don't know if it's all just because of the shortening or when you look at it from behind.
It's probably because of the loss of he has a bit of hyperextension and the loss of the skin in the subacute plane because of multiple surgeries, but he is definitely having a bit of hyperextension. I agree.
Yeah, and even on that lateral X-ray or the slightly, I get the impression that proximal epiphysis of the tibia is sloping in the other direction, wrong direction, right? Normally there's a 10-degree tilt the other way.
You can see a fascial scarring probably here.
Yeah.
It's irregular. So this is all part of global infection.
Yeah.
So some element of Hoyter-Folkman also coming into play, probably.
Sorry?
Flexion, there is a flexion deformity distally, so the body tries to adapt with a little bit of hyperextension at the knee, so that the flexion deformity is not evident. Right. But as he pointed out, you probably need to keep a watch in terms of future.
So let's show you what. So we made this frame considering the double plane deformity, and
it's a single plane deformity. It's a single plane deformity. It's not a double plane deformity.
It's an anterolateral. It's not. What I meant is.
So that's what I'm trying to sort of when people think in two dimensions, then it's a two plane deformity. Actually, it's a one plane deformity.
Yeah. So it's a one oblique plane deformity.
Yes.
Right. So why I mentioned two is it's not only coronal, but there is also sagittal. And if you take a cumulative, that's a anterolateral deformity. So the hinges were placed in same fashion and distraction device. This is how it was placed, and this was immediate post-op. And we started distracting, and most of the times as we start distracting, and by the time the hinges become straight, we gain the length, and this was a year later. So deformity got corrected and the length also got corrected. So we did not lengthen it, but we just, as Dr. Mangal said, we corrected it, and it got the length also. This is an X-ray after a month after removal of plaster. He is probably short by about a centimeter, and I will deal with that later if by contralateral epiphysiodesis. But now that extension has resolved partly, Dr. Sabharwal.
Yeah, no, it looks very good.
Yes, so Dr. Mangal, your comment on this.
Yeah, perfect.
That's the same case you showed, the same outcome. Right. So let's move on to the last case. This is interesting. Now this girl has undergone again 4 or 5 surgeries before. She had an MRSA systemic sepsis with chest wall infection and abscess along proximal leg, which was drained by a pediatric surgeon. She was in ICU for 6 weeks, and then she had an pan-osseous global osteomyelitis. So you can see the scar. When I opened up from the top, the part of proximal medial metaphysis was in my hand. It was sequestrated. And I also made a distal incision, did a giggly saw assisted decompression of the disease. And then gradually she drifted into varus, and the fibula is becoming prominent here. And she has a bit of recurvatum deformity, which made it more prominent. So she has also a bit of shortening, and this is the X-ray. So you can see this gap. This bone, when I opened, this bone was loose and it came out. And through that window, I drained it completely. So now the disease has healed, but she is ended up into Genu Varum, and the deformity is progressing. So, Dr. Sabharwal, how would you, what would you like to have further information, and how would you approach this case?
Yeah, firstly, I was just curious, what did you do with the jiggly saw, Maulin? You said you used it.
Yeah, so that is our native technique I have been using for now 12 years. So for children with pan-osseous osteomyelitis and very small bones, we cannot use a solid reamers to decompress the medullary canal. So with a giggly saw wire loop, we can pass it into small bone and we scrap the medullary canal. And that's how we decompress. And that's how also we can retrieve some loose sequestra. So now this technique has been used in more than 100 children. Somehow my paper is not getting accepted because we do not have controls. And I will talk about it in greater details in some other time, but it's a lovely technique of doing intramedullary decompression in younger children with pan-osseous osteomyelitis.
So you go like proximal to distal, like where would you go? Like in this
so
case?
I need a small window in either, if the disease is more proximal, then I start there because that will local decompression is done. And through the small window, the loop of giggly saw wire is introduced. Sometimes the window is small, I compress that loop and I pass, and then we bend it at tip, and then we rotate and scrap the walls, anterior, posterior, medial, lateral, after looking into IITV. And that's how, without destabilizing bone further, you can decompress. And it is followed by placing an infant feeding tube. And we have fair number of cases. I'll share my presentation to you sometime with video.
Yeah, definitely. No, worth sharing with everybody, you know, with the publication. So, okay. So this case, it sounds, she's how old? 5, 6?
Yeah, she's 5 years old now.
Yeah. So it sounds like, you know, the infection probably, well, almost certainly affected the growth plate as well. And there's a little bit of a bone defect. So it would be nice to somehow image the physis, even if we get a better cone down X-ray, you know, looking right at that proximal tibial physis on both planes, I think would be good. And, you know, it looks like, oh, and you got an MR, even better. So, yeah. So you could see there is medially, as expected, in that bottom, exactly. So there is, there's definitely some kind of a tether there. And it's also interesting, you can see that proximal tibial cartilaginous onlog, which seems actually pretty good and congruent with the distal femur. So that's a good thing. And again, an arthrogram would have probably helped there too. So I think the big problem here is the physeal bar. Do you have any lateral images too?
I had axial images which shown that the bar is quite more located posteriorly than anteriorly.
Okay. Yeah, which would make sense.
It was a linear bar, which we would not like to kind of non-amenable to excision, but it was there.
I see.
Unlike this post-traumatic bar, this was a bit more extensive. And as you can see in this image, there are multiple levels of these things going.
So yeah, I mean, again, if you're asking what would I do, I think if you have enough info, one option, like you said, would have been to do a physeal bar excision plus minus a growth modulation on the opposite side to at least give it a chance.
Yeah.
If you feel, and obviously post-infectious are not that amenable
Candidates.
to, yeah, doesn't mean there never are, like a
No.
spot weld post-infectious peripheral bar in a young child probably would still, be a possible indication for bar excision. But in case that's not, available, then I guess you're left with, you don't want this to progress further and you have a deformity to correct. So I guess, and you also want to take care of the healthy physis so it doesn't, get worse. But then again, she's so young, she has so many years of growth remaining. So I think it would be obviously a conversation with the family that you may need to do, stage things. But the first thing is to prevent this from getting worse. 2 would be to correct the deformity. And then 3 would be to address her leg length discrepancy over time.
Right. So this was very difficult. This child had undergone a lot of things. She had hearing issues, so she had undergone cochlear implant surgery and a lot of stay in PIC. So this was difficult. The family had undergone a lot of trouble. So we explained that by trying to excise this bar, we want it to prevent from getting worse. And by growth modulation, we'll try to stimulate the opposite side. And now the deformity was more than 25 degrees in the proximal tibia. So there is a literature that when you want to do a bar excision, and if the deformity is more than 20 degrees, then you correct it acutely, because in the existing weight bearing or loading on that side, the bar excision may fail. So there is some literature. So I also coupled it with a osteotomy also. So we know that results of bar excision are not great, but if it is focal bar, then it will help us. And as this child was being pretty young, I tried to give a chance. So when we opened it up, and you can see on the end, this is the tibial epiphysis, and this is the part of bone which was lost. And here you can see that bar, the bony bar at the physeal side, and I excise it, burred it, and I placed cement. So what we do is we make a glue of cement, put it, and then take it out like a candy. And once it gets settled down, it gets the thermal reaction is off, then I will reinsert it so that it does not produce thermal damage to the surrounding physis. And then did a dome osteotomy of proximal tibia, and also placed an 8 plate so that I would stimulate the medial side of growth, just medial to the cement where the bar which we place the cement in. So this was the final picture. I did, of course, fibular osteotomy as well. So Dr. Mangal, your comment on this?
Yeah, I mean, I would probably have used an Elizarov to achieve the same thing with less trouble as far as I am concerned, and I can get it straighter. But as I said, ultimately it's the principle which counts. This is how old now, this correction?
This was post-op X-ray. Now I have further follow-up. Let me show you. This is 4 years follow-up. So the amount of valgus which I have got has remained the same. But if I look at the physis, I mean, there is some physis on the medial to the cement. And the child is short by 1 centimeter. So I doubt that whether the whole physis has fused, but it doesn't look like, because it has been 4 years. If it has fused, then the discrepancy should be 0.6 centimeter per year. So 2.5 centimeter, but it's just 1 centimeter. So I think things are growing. And,
no, but I think that the tibia is definitely much shorter than 1 centimeter. She may be compensating by overgrowth in the femur. If you look at just the tibia, that doesn't look like a centimeter of shortening on the AP. So the point is that whether instead of doing the bar excision, one of the things which I would think of is stop all the growth. Because anyway, this child is going to require
lengthening or
so stop
but there
all
are
the growth.
But there are saying that there are instances, I should share a few cases of infected bars, and there I have documented the growth. We have placed that wire in the metaphysis and the things have straightened. So I remember one of femoral, there are 2 cases. So even infective bars, if we excise and they are focal, so then they won't need any lengthening.
In a limited situation, yes. But I'm talking of in the whole context of a deformity, a non-union, with multiple other things thrown in. There, it could possibly be simpler for me, at least, to do this correction and then stop progression of the deformity by obliterating the remaining growth. Now, this is I personally have very little experience with excision of bars, and I think somewhere I may be technically lacking in that, in terms of getting that particular thing done.
I mean, you receive cases at the end of everything is done by us, so you don't receive them earlier, but that can be done by you also. By and large, these post-traumatic bars are there better cases than post-infective. But here again, like doing a complete physial ablation at 5 years, meaning that the child has more 8-9 years growth remaining. So that will lead to 6 centimeters of shortening. So at least one should.
Yeah, but right now at 4 years follow-up, what I can see on the AP X-ray, 75% of that epiphysis or the lateral part is gone already.
Yeah,
and that's how the epiphysis tends to respond. So yes, I don't know that this is necessarily what I'm saying is necessarily the right method. But in post-infective, there are other things at play.
Yeah. So we now in last follow-up, I explained to family that we would need either ipsilateral lengthening or contralateral epiphysiodesis. She is now 9 years old, and in a year's time, we will consider limb length equalization. Probably if we want to go for a contralateral proximal tibial epiphysiodesis. Because I don't want to lengthen this tibia. A lot of things have been done already here. We'll see. I'll keep on posting you. But
Maulin, very nice case. But like you said, there's still more to the story, right? Because she has growth remaining. One observation to Mangal's point, and what you said too, is look at the proximal fibula on the 2 sides. Right? You see, that just tells you that the proximal fibula is so much more proximal on the right than the left.
Yeah.
So, perhaps, and I think with time and more growth remaining, that might actually go even higher. So I'm not sure.
Yeah, so if we plan to do a contralateral epiphysiodesis in a year's time, I should epiphysios this fibula also, probably.
I think so.
Or what is your suggestion, Dr. Parihar? Or should I lengthen the ipsilateral tibia and then bringing the station down and fix it with a wire?
No, I wouldn't bring it down, but I would certainly think about stopping the growth. There's one more observation, which I don't know what you have to say, what Sanjeev has to say, is a lot of patients like this, where the tibia has stopped growing kind of, and the fibula continues to grow. They develop a rotational deformity because the head of the fibula is posterolateral above and kind of, relatively speaking, lateral below. So as the fibula grows, it not only tethers it to create a little bit of varus, but it also imparts a certain element of rotation. This is something that I have seen in some of these patients. You see the way that on the lateral X-ray, that orientation of the fibula on the affected side, on the other side, it's absolutely straight.
It is bowing because of the tibia is not growing at the same pace.
Lateral of the femur above, but you see the overlap of the fibula to the distal tibia on the normal side. There's much more overlap on the affected side.
Yeah. There's some rotational element. So I'll keep an eye on this, and that's a good learning point. I was thinking of doing just opposite proximal tibial epiphysiodesis. Now I'll add on the fibula also on the ipsilateral side. Right. So thank you very much for your time. And there's one more question. Yeah. Okay. So thank you. In nutshell, like we discussed all the modalities of treatment. Yeah, this is her current photograph. She has good range of motion, and as Dr. Mangal said, a discrepancy is little more than a centimeter. So we'll measure it appropriately, and this is the plan. So thank you very much for your time, and we discussed right from weightful observation to bracing to growth modulation to corrective osteotomy and to Elizaro assisted correction, and finally the bar resection also. So each Genu Varum case present different challenge, and based on experience and the advices by our experts, we have to titrate the mode of treatment, and they all are interesting bunch of cases. So your final comment, we have overshooted by 15 minutes. Dr. Sabharwal, thanks for your time. And we learned a lot today.
Thank you, Maulin, for sharing this. I'm really proud of you and your group, and keep it up. Really, if you do this every week, I want to be a part of this. I want to learn too.
So I have your WhatsApp number. I'll keep on sending this information. That Sham Kishan always Mihir, they usually participate.
That's very good.
Yeah.
Excellent.
It's an evening. Yeah. Thank you very much. Thanks, Mangal, for your. I learned a new point. I'll find out that ball to put it on the level of femur as a magnification marker. I used to put it in the front so far.
Sure.
Thank you very much.
Bye-bye.
Bye,
Thank you.
guys.
Take care.
See you.
Bye-bye. Thank you very much.